So a bit about the genoma, what we call the map of the genes, mapping, genoma. Somewhere I could read that there was a question about the weakness of the cell wall, and which you could detect by the NOD2. NOD in the gene map, is it really telling us that we have weaker cell walls than other people, and that therefore MAP is easily, let's say we are opening the door easily for MAP to enter in our cells, so that MAP is intracellular accommodating itself, and that other people, that they have these walls stronger, and even having MAP in their bodies, that they would not have such an attack of MAP in the Crohn's, so that there would be no evidence of Crohn disease in their gut, but they can have and be parting, let's say, the MAP. And is that possible?
Yes, is the short answer. There's been very good genetic research done on humans,
yes,
to try and pin down those regions of the human genome,
yes,
which are associated with significantly greater susceptibility to Crohn's disease.
yes.
And these are homing in on a sort of common pathway. The NOD2 card15 gene, for example, is involved in signaling inside the cell in response to bacterial products.
Yes.
And then there are two other important places in the human genome which are affected in a significantly greater proportion of people with Crohn's disease, and they damage the ability of cells to destroy bacteria inside them, inside cells.
Yes.
So what you say is absolutely correct. We should be clear, however, that for example with NOD2, only about 20% of Europeans with Crohn's disease have a NOD2 deficiency, meaning 80% don't. And the NOD2 system, for example, of susceptibility in Crohn's doesn't apply in people from Japan or Korea or China or Tunisia.
Hey.
So, and I just saw something recently about southern Spain. So it is quite clear that there are other factors, perhaps other genes, but also other factors to do with the MAP bugs themselves that determine whether people who are exposed to these organisms come down with disease.
Yes. The second part of this same NOD2, the NOD2 question which I have, is that some Swiss investigators are saying that MAP is easily entering the cell, but so do not the medicines to attack that MAP.
Well, that's perfectly true. MAP is, as far as we know, a uniformly intracellular organism. And these class of organisms, the M.A.P type of organisms, where they cause infection and disease, they are very, very difficult to eradicate. For example, most drugs that people are familiar with that work against tuberculosis don't work against MAP bugs. However, in 1992 I did introduce some new treatment for people with Crohn's disease infected with MAP, using two drugs called rifabutin and clarithromycin. And these in fact are both concentrated inside cells. So which is very good, of course, because that's where the MAP bugs are.
Yeah.
Mark you, inside the cells, it isn't just a uniform space. There are lots of little bubbles and vesicles, as they're called, inside cells where MAP also resides. So whether the drugs get into those is another question. But it is clear that some drugs cannot enter cells, and MAP bugs almost certainly do. So you have to pick drugs which will enter cells in order to be active against MAP?
We started in our antibiotic world with penicillin, and this is developed in Tetra, and then tardocillin of Bayer, and later on the aminobenzyl penicillinus and so on, and we arrived to what we are just now. You explained me the clarithromycin and the Rifa were just the drugs you found able to attack in certain sense the MAP inside the cell. My question is now, in the pharmaceutical development history, which we will have to see in the next future, is Rifa and the other one, are they the beginning, let's say? Do you think better and refined drugs will come out of this through primary materials you found out?
I think that rifabutin and clarithromycin will make a very useful contribution to the treatment or anti-MAP treatment of Crohn's disease. They already have, and the work that researchers spend years contributing to, like Dr. Tom Barodi in Australia, will carry that forward to most important clinical trials in this country, perhaps in the United States and so on. And it's not that a treatment necessarily needs to have to work all on its own. It can be helped by other treatments. Now, it might be the case, and Tom Brody and I were discussing this recently, that infliximab may actually work together with rifabutin and clarithromycin and very much improve the responses to each other. We also expect that there will be new generations of drugs following on behind this, some perhaps coming out of the development of new drugs for the treatment of tuberculosis that do work against MAP. But yes, I think we are in the early stages. It's more than a beginning. We're a bit farther down there. But we are in the early stages of a whole new set of treatments for Crohn's disease.
How can you value, or what can you comment on the several publications which has been given to public by other hospitals where they have been trying out this Rifa and this other drug? I mean,
clarithromycin.
Yes.
You're talking about the Australian
Yes,
trial.
I want to say the publication in which they said after 2 years it was not active anymore, and so, I mean, is it because of methods, because of some other strange situations?
The answer is simple. The randomized controlled trial of rifabutin, clarithromycin and clofazimine, designed and conducted in Australia, was deeply flawed. The trial design was wrong. Too many patients left the trial early on because of the flawed design, and they looked at the wrong outcome of the disease. What they should have done is designed the trial as a remission study, which is standard in Crohn's disease. That is to say, do the tablets make the people better? And if they had done that, then they would have found what our statistical people here, for example, and others have found, is that rifabutin clarithromycin conferred a highly statistically significant benefit at every time point in the treated group compared with the control group throughout the whole 2-year period of treatment. Now, I'm afraid the Australian trial just created uncertainty. It wasted about $3 to $4 million and 5 years and the participation of the patients and families with Crohn's disease. It is a tragedy that such an opportunity and so much money was wasted. And it has to be done all over again to get the right answer.